Hello and good afternoon. My name is Zulima Chavez, and I'm the Support Center Manager for the Asthma and Allergy Foundation of America, or AFA. This episode is produced independently by AFA and made possible in part by support from AstraZeneca. Today, we're talking about what asthma is, how to manage it, and current treatment options with Dr. William Anderson. Dr. Anderson practices allergy and immunology at the Children's Hospital, Colorado. In this role, he is the director of the Multidisciplinary Asthma Clinic, medical director for the Allergy and Immunology section at the Children's Hospital Colorado, and co leads the Children's Pediatric to Adult Transition efforts. We are also joined today by Dr. Matthew Greenhawt, AFA's Chief Medical Officer and Pediatric Allergist, who will be leading today's conversation. Welcome to you both, and thank you, Dr. Anderson, for joining us in today's episode.
Thank you for the invitation. Very happy to be here.
I'm going to further disclose that Bill and I worked together for about 10 years. And, he was my go-to resource for asthma when I had a question or whatnot. So we're really lucky. He's one of the foremost experts in the US, and super happy that he could join us today.
Thanks, Matt.
All right. So Bill, let's start with the basics. To a patient, how would you explain what asthma is and sort of how common it might be?
Yeah, asthma is extraordinarily common here in the US and around the world. Over 28 million people in the United States have asthma, including over 23 million adults and almost 5 million children. It's the most common chronic illness of childhood. So, asthma is a condition where you have inflammation of your airways that lead to these recurrent symptoms, which I'm sure we'll talk about later, including shortness of breath, coughing, wheezing, that can be improved with the use of bronchodilators, which are medicines that help to open up the airways, as well as anti-inflammatory medicines that can help decrease this inflammation. And we know that there's common triggers for asthma as well, including viral illnesses and allergens.
Yeah, but you've heard me sort of hack away in clinic many a Thursday for multiple years. That's an excellent description. Yeah, I mean it's there are about 28 million people in the U.S. with asthma, 23 million adults, 4.9 million children. I mean it is a very prevalent disease, and I think honestly, underdiagnosis may be a huge issue too. I've lost count the number of times I would see somebody coming into clinic, they have like a 4-year history. Like, yeah, 5 times a year I get sick, I cough for 6 weeks, and you're like, yeah, that's probably asthma or something like that. And I was a kid like that, and it's one of these things that I think awareness is better these days, but still we may be sort of missing the mark. So let's just say that you're one of these patients who may be falling through the crack for whatever reason, that you've walked around with a recurring cough or whatnot for multiple seasons. What are some of the symptoms that you would sort of worry about, either at the primary care level or at the specialist level? What are the types of things that we worry about? What's the pattern of illness that we see that makes sort of the diagnosis of asthma sort of bubble up to the top?
Yeah, so, and Matt, you bring up a great point that a lot of, as we know, asthma has a significant genetic component, and often we see it running in families. And you hear histories of like grandma had this, and then dad had this, and then now a kid has this, and they're like, well, it's asthma. You cough, you wheeze. It's what you do with it. But I think that's underestimating what this disease really is. You should not be walking around with a cough all the time or wheezing all the time. And so, if you do notice that you have recurrent respiratory symptoms, whether that's cough, wheeze, shortness of breath, feeling tight in your chest, these are all symptoms that could be consistent with asthma or other respiratory diseases. We also note that both children and adults can have symptoms induced with exercise. So if your kid or yourself are running around playing, being active, and you have to stop because of shortness of breath, certainly you want to have that evaluated. If you're waking up in the middle of the night with trouble breathing, that could also be a sign of asthma. And then if you have these recurrent exposures, you mentioned a viral illness, getting sick, getting knocked down with respiratory symptoms, something certainly you want to keep in mind. Or when you're around a recurrent trigger, that could be an environmental allergen like pollens or cats or dogs, or an irritant like smoke or pollution. So clearly, if you're having recurrent respiratory symptoms, it's worthwhile taking them seriously and seeing your PCP, and your primary care doctor may subsequently refer you to an asthma or respiratory specialist.
Yeah, I mean, the one thing that always shocked me, again, I'm guilty of this, but as a child of the '80s, the asthma awareness when I was growing up was, asthma was an inpatient disease. Now it's very much an outpatient disease. The way I always framed it is, there are like 3 or 4 kids on the soccer team that your kid is on that's going to have this, and they're the ones that are coughing. They're not going to pull themselves off the field, but they're the ones that like they missed the pass because they're doubled over coughing or whatnot, or I mean, and just the acclimation that I think you can, like you said, it's not normal to do, and it's not just with this allergic disease, like with eosinophilic esophagitis. The number of people thought it's normal to just sort of impact on the 4th of July and get it fished out. It's sort of people acclimate because they're used to it, but we can do better. So,
It's
all
I
right,
was gonna say,
so
Matt, it's
yeah,
really it's like that acclimation aspect of it. You ask kids and adults, do you have any exercise-induced symptoms? And they're like, no, I don't. And you say, well, how often do you exercise? Well, I don't exercise because then I'll start coughing. And they're like, okay, yes, you do. And now you're just kind of readjusting what is normal for you.
yeah. And it's subtle. Just the teacher can see it at recess. The kid, I think they still have recess or whatever. In our day, we had recess, and it's the kids that just they can't keep up on the playground or what. I mean, it becomes very apparent. You know it when you see it, but sometimes it's so hard to recognize it because it's in front of you and you've seen it every day, yet you don't necessarily, maybe it's not so abnormal. But
Mhm.
all right. So now we used to see the tail end of this after they should have presented to the emergency room or whatnot, and we're dealing with the aftermath. But for when it's happening, what are the symptoms? Like, what would prompt you to recommend when a patient should go seek, urgent care, emergency care, go see their primary care, whomever?
Yeah, so I think you can think about this in two different ways. If you have someone who's never been diagnosed with asthma before, but you're having these severe symptoms that are now interfering with your daily activities or interfering with or prolonged symptoms after illness or really having a struggling time breathing, you certainly want to seek emergent care. And if it's not an emergent episode, talk to your primary care doctor. Now, assuming you have been diagnosed with asthma, the hope is that you've been given an asthma action plan. And an asthma action plan outlines it in it a green zone, a yellow zone, and a red zone. The green zone is what you take on a day to day basis, assuming that you're doing great. A yellow zone tells you what medicines you should take if you are having worsening symptoms. So, that cough, wheeze, shortness of breath, chest tightness that we mentioned. And oftentimes, those are what we call our quick relief medicines. And then a red zone outlines when you should be going to the emergency room. And typically, if you are using your yellow zone medicines, which should tide you over for anywhere about 4 hours or so, if you're needing it more frequently than that, that's when we say time to come into the emergency room. But obviously, I want to be clear, if you are struggling to breathe, can't get a sentence out, turning blue in your lips, feeling tired, these are all signs that definitely straight to the emergency room.
We'd like to see you before
Yes.
you hit that point. It's a
Well
lot easier
before
to
that
deal with
point.
problem. Yeah,
Yes.
when it's
Yeah, if
when
you
it's
are
milder. Yeah,
yeah, it's exactly, Matt. Like when you have these mild symptoms that are happening a couple times a week, a couple nights a month, these are the signs and symptoms that saying I should start seeking attention. If it's progressing to those other levels, we've missed our mark and we're kind of in a rescue mode at that point in time. We want to be proactive. We want to identify you early on so that you don't get to that point.
yep, excellent. Okay. So and I'll emphasize that you can go to AFA's website, www.aafa.org, where you can download copies of our asthma action plan. This is a shameless plug for our own resources, but it's a very good plan. You can download other action plans there too in English and Spanish, but these are resources that you can freely access. It's one of many asthma action plans. I think it's a very good one, but we'd rather you have something is better than nothing. If not our plan, somebody else's is fine. But it's there for you to look through, and these are things that help. Just sort of align. When are you losing control? What do you do when things are good? What do you do when things might be moving towards something? And what do you do when it's clearly past a point? But with that, let's talk a little bit about control. Like, there's guidelines and whatnot are going back, trying to define control, impairment, of lots of ways for us to figure out sort of how bad is your asthma? What medicine do you need? How do we move you up and down? Like, what do you define as poor control? What are some of the symptoms that you would think is sort of poor control? And sort of what types of limitations might somebody have as they're losing control?
If I am a patient with asthma, I want to be thinking about how it's affecting me and my life. If I am having difficulty doing my day to day activities, or maybe not completely preventing me from doing it, but if I'm taking a step and I'm saying, hey, maybe I'm not going to do this because it might trigger symptoms, that's a sign for me that your asthma is not well controlled. And you can also see symptoms during the day. That could be coughing, wheezing, shortness of breath, interference with activity, things like that. You could also have nighttime symptoms where you are waking up at night with coughing or shortness of breath. A common way, if you do have one of these quick relief medications to kind of think about whether you're well controlled or not, is if you're needing to use your relief medication more than twice a week, that is certainly a sign that you are not well controlled. If you're waking up a couple nights throughout the month, at least 2 nights throughout the month, that's a sign that you're not well controlled. But beyond just these like day to day kind of symptoms, are you ending up in the emergency room? Are you having unscheduled visits with your primary care doctor or your asthma specialist? Or, worst case scenario, are you admitted to the hospital for these? If you are having symptoms that bad, even if you're great the rest of the time, but you're having symptoms bad enough that you end up in the emergency room 1 or 2 times a year, that's a sign for me that we're not well controlled. So it can be something that affects you on a day to day basis or a couple times a month, or it could just be 1 or 2 really bad episodes throughout the year. And all of these can be signs of being poorly controlled.
Yeah. No, I agree. Certainly, the last thing we want to do is visit you in the intensive care unit. That's certainly one marker that you've lost control. We'd rather see you when you're starting to progress, like, yeah, I'm coughing a lot during the week, and maybe I've got a prescription inhaler, and I'm starting to use it more. Like, that's when we want to intervene. Some use is fine. Obviously, that's what we prescribe it for. But it's this repeated use. You're going to have to use something to control your asthma. It's about progressions, and there become better choices or whatnot along the way. We'll emphasize that ideal management is you don't have to use any rescue inhaler,
Mhm.
but like if you have exercise induced asthma, we don't really count that. We watch to see, do you break through, if but counting those uses, counting the times that you wake up in the middle of the night and things like that. And there are measures, they call them the asthma control test. These are actually measures that we get graded on how good of a specialist or a generalist we are if we don't record this, so we can track you over time. So there are measures that we use. You can look up the asthma control test on online, to understand sort of the criteria that we're using to make a quick judgment. Are you well controlled, or are you moving in a direction? And the nice thing is that we have lots of steps that we can march you through in terms of, you're starting to lose control like this. All right, here's what we can do for you. So there's lots of things with that. And I'm going to pivot because you mentioned something
Yeah.
about the short acting stuff. So let's talk about what you can do. What are some of the medications that we have at our disposal? Start with sort of short acting things to more chronic, and guidelines advocate for a lot of things, but like, as when we see you in the office, what are we looking at? What are our basic tools, and sort of how do we move from one tier to another?
Yeah. So we can certainly start by talking about medications. In general, we think about our medications into two big categories. One is our quick relief medications. In the past, we've called these rescue, but now we're moving to this term of quick relief medications. And these are medications that act quickly to help open up your airways, to bronchodilate, to help relieve symptoms. And some of those ones include albuterol, levoalbuterol, and now there's even some formulations that contain some steroid in addition to those quick acting medications. The next category is our controller therapies. These therapies are designed to help reduce that inflammation that we talked about at the start, to help hopefully prevent the onset of symptoms. And those are typically our inhaled corticosteroids, or inhaled steroids as they're called. There's also some oral medications like Montelukast, but usually the majority of our control medications are inhaled, and they can be just the inhaled corticosteroid alone, or they can also have a long-acting form of a bronchodilator. We in the business called a LABA, but essentially think of it a long-acting form of albuterol. And then finally, if you're really poorly controlled, some medicines that we can use as well include the biologics, which are injectable medications that are specifically targeted to interrupt inflammatory pathways. So, those would be the big medication aspects that we use to control. Obviously, we also talk about identifying your triggers of your asthma and avoiding those. And if you come to see Matt and I in a clinic, we're going to do allergy testing on you to talk about how we can identify those triggers and hopefully reduce your exposure to them. And then, last but certainly not least, we want to make sure you're taking your medicines correctly. So we talk about adherence and technique as well.
Yeah. I mean, it is two parts. It is identifying what sort of sets these episodes off and trying to reduce that. But then it's sort of an escalator of different therapies that could be used. And there are different situations, and sometimes you're on a couple of things. People always ask me, "Well, how long do I have to be on this?" And my answer is, as long as you need to, but as short as I can get away with. I mean, we don't want you to be on medicine any more than you want to be on medicine, but these things really, really work. And we've come a long way from, in the old days, we used to give, before EpiPens, we give epinephrine shots. And
Uh-huh.
and something called theophylline, which is a wonderful drug as long as it stays within a very narrow range. But we've come a long way from, both of us, we're in Denver, and there's an institution here that basically made its name on sort of long-term inpatient management of asthma. And the nice thing is that all that research has shifted this now to quite a manageable outpatient disease with the right drugs and whatnot. But all right, let's go back because I really want to talk about this. And one of the things that's become confusing now is sort of the controller or the immediate relief. How do we deal with that? When I was starting out with my asthma journey, we had just one. It was albuterol. It was a short acting thing. It lasts about 4 to 6 hours. And then we evolved into longer acting things. And now we've got things long acting, short acting, without steroids. Can you just sort of talk about that pattern, especially since there's been a big push and a lot of data has shown, why are we adding steroids to things that are intended to be sort of short acting controllers, and what's the advantage?
So the historical thought on this was if you have very rare symptoms, we can use just albuterol or just leave albuterol alone, and you're otherwise going to be great. But if you start having more persistent symptoms, then let's start you on a daily therapy. But the data has shown that even those patients who are just taking albuterol alone are at increased risk for severe outcomes such as hospitalizations or emergency department visits. And as we know, associated with those are costs. There's the risk of having to take other medicines such as systemic steroids or a oral steroid course. And then also, as we mentioned, about long term implications of these recurrent exacerbations as well. So, based upon that, there have been studies done that looked at these patients that were just getting albuterol alone or a quick relief medicine by itself alone. And they actually said, what if we give them a small amount of an inhaled corticosteroid at the exact same time? And they found that those patients had a significant reduction in their chances of having severe outcomes like hospitalizations and emergency room visits. And they found that overall they had improved asthma control. And especially for us as pediatric doctors, we worry about, well, we don't want to give kids more steroids than they need to give or anything along those lines. And what we've actually found was those kids, while they got a slight bit more steroid because of that approach, the outcomes were no different in terms of the adverse events. So we're giving them a much bigger benefit with relatively minimum adverse event on top of it. So that's why we're now moving to this approach, which we in the business called air anti-inflammatory reliever therapy, where you're using both an inhaled corticosteroid at the same time as you're using your bronchodilator or your quick relief medication.
I think there's been some research going back and forth for years whether to add, do you use inhaled steroid in the acute setting or whatnot? And so it's drugs that we're not going to mention the trade name, but it's a combination budesonide, which is a steroid, and albuterol. This is the hottest thing, and we just came back from a meeting, and this is all over the place, and people are talking about this. So this is something that you know really could supplant just the use of albuterol alone, which still works quite well. If that's what you're on, please don't fret about that. Like next time you're in, you can talk to your prescriber if that's right for you and what situations, but just having this by itself is say it's worked in the past, it's going to continue to work in the future. Yeah. All right. So let's say that you sort of graduate out of, you've done so well controlling your disease that, wow, boy, I think I need something else. So what about the next step? We'll just sort of bin these, we'll talk about the SABA, the LABA, and then the biologics. So, all right, your asthma, it's not quite responding to even the short acting therapy with the steroid. What's your next step?
Yeah. So the next step, if you're just using an on demand therapy alone and you're not having great control, that's when we start moving to a daily controller therapy. As I mentioned before, historically, this has been inhaled corticosteroids alone, but we're now seeing more and more evidence that it's good to be on a medicine that has both the inhaled corticosteroid combined with having the inhaled corticosteroid combined with a long acting form of albuterol or that LABA. And with that approach, you're able to control your inflammation throughout the day, but also keep your airways open throughout the day. Now, there's certain formulations of these ICS LABAs that you can actually use both as your controller therapy and as a rescue therapy. So you would take your 2 puffs of your controller in the morning, 2 puffs of it at night, or one and one, depending on what your doctor would recommend. But then throughout the day, if you develop symptoms, you'll take this same exact medicine again to help open up your lungs and give you a little extra burst of that inhaled corticosteroid therapy.
And so we call those smart inhalers, right?
So single maintenance and reliever inhaler, smart.
And it'd be great if they had more than 128 puffs, which comes out to 2 puffs twice a day for a month. That's another future
But we
episode.
do
We can
know,
talk
Matt,
about
that
that.
I'm sure all of the people listening to this that have asthma are taking their medicines perfectly. I'm just joking. We know that people miss doses of their medicines. And by even taking it on demand, so say, for example, you get your 2 puffs in the morning, you sometimes miss your nighttime dose, but if you're taking an extra puff during the day, we're getting closer to what you should be doing on a regular basis.
Yeah, yeah. And I will say these smart devices, they contain the long-acting agents called formoterol, which is uh, really remarkable, and it gives you sort of the quick onset of action, and it lasts 12 hours. So as somebody who's used that, it like I was a little skeptical the first time I did it, but yeah, it really does. So it's another great option. All right. And then if you continue to excel at your asthma control, what's sort of for dessert here in terms of where you graduate to? Let's say that it's not working with the short acting or the long acting with or without steroids, probably with steroid at that point.
Yeah.
What's the next thing that we do?
The next step, if we've failed those therapies, is a biologic therapy. So these are medications that are specifically designed to interrupt inflammatory pathways that cause asthma. These are all modified antibodies that bind to specific targets. They're all administered as an injection. One for adults is also administered as an infusion, but most of these can be given subcutaneous at home. These medicines work fantastic, especially for our patients who have very severe asthma. The main reason why we use them at the end is simply because they're a costly therapy, but there are some really interesting studies that are being done now to say, hey, what if we use these therapies earlier? Can we prevent the development of symptoms or the progression of symptoms? So that might be, if I come back on the podcast in the future, what we'll be talking about instead. But for now, they're at the end of that pathway that you mentioned.
Just want to go back to something about the controller medicines, understanding what you use for rescue, what you use for controller, sort of where the lines are drawn, because we don't want somebody taking the wrong thing. How do you counsel your patients in that? Because it can be very confusing. Somebody could walk out easily with what, two inhalers, three inhalers.
Yes, certainly. If you're going to be using a rescue medication, we want a medicine that acts fast. So you want to look for ones that either say albuterol on it, leave albuterol, or formoterol on it. The other medications that are just an inhaled steroid alone, those ones will not help you out quickly. Or if it says an inhaled steroid plus salmeterol, which is a different type of a bronchodilator, those ones will not work fast. So essentially, if you know which one are the fast working ones, albuterol, and formoterol, those will help you distinguish what to use in a rescue, and the rest are kind of your controller medication.
And then just one other note, the limitations of the short acting thing, sort of what can and can't serve as a controller. And now with something with a steroid in it, sort of message to you, like, I mean, these are the things that we're hearing, the
Yeah,
cautions that you need
certainly.
to have with
Yeah, and it
that.
can get confusing. And so if you are on one of those medicines that is the two-in-one medicine, where you have both an inhaled corticosteroid and a quick-acting bronchodilator, if it is the one that has both albuterol and budesonide in it, anything with albuterol is just short acting, and those should just be quick relief medicines. Versus the ones that have formoterol in it, and those are the ones that can be used both as maintenance and rescue together. So I know it's a little bit of a complicated hodgepodge of names and words here, but that's where also really instruct you to look at your asthma action plan, because your doctor will put on there, this is the one that you use on a daily basis. This is the one you use when you develop symptoms, and really follow that and have that available to you as well.
And the other thing I'd say is if isn't being explained for your child or yourself in your own visit, please stop us and make us explain it to you. This is something that we should do. Sometimes we're moving fast. Sometimes we forget we need prompts. If you prompt us, we were not offended because everybody's got to help each other out. But yeah, I mean, you should know when and why you're using each medicine. And again, this is why you have the asthma action plan. It's supposed to explain this to you.
Yeah, I would say first and foremost, make sure that your doctor, and if not your doctor, your pharmacist, somebody actually tells you how to use the medicines, because they're not all used the same. Some are you do a little puff and you need a spacer or a tube to help inhale the medicine, and you want to pause before that you inhale that, or inhale it slowly. Other ones you puff and just inhale directly from the device. So these are all, it's important to recognize that there's many different formulations of these asthma medicines, and we want to make sure that the one you are using actually works for you and you're able to take it appropriately. I really discourage the use of anything that requires an active inhale, like a dry powder, for very young children, because they just don't have the inspiratory force to do that. Older children, teenagers, adults can certainly do that, but I think that's where we oftentimes get tripped up. So certainly knowing how to do it. And then, as we all know, our formularies change, and one medicine that was covered for your asthma today may not be covered tomorrow. So don't necessarily assume that medicine is going to be taken the exact same way, and talk to your healthcare team about that if you do have a change in your therapy.
And we do mean that today versus tomorrow, because both of us have walked in having prescribed something on a Wednesday. You have to change and do prior authorizations for the same medicine on Thursday because they switched the formulary. So these things do catch us off guard. So in the last couple of minutes here, I want to pivot to something and talk about one of your research interests, which
Yeah.
is transitioning care. We struggle with this with all disease states, but in asthma, sort of, when is it appropriate for the child to start of take more control of their management? When is it appropriate for the adult, as we are dealing with something this morning with our own adult child in college? When do we stop sort of managing their medications, and when should they be taking over? And
Yeah.
sort of,
So
what are you doing to address that?
being trained in both pediatrics and adults, this idea of this transition from care from pediatrics to adult care has always been near and dear to my heart. And the idea is that we want to empower our pediatric patients to have those skills to self-manage their asthma as adults. And I think that first and foremost, early in life, like in the first few years, when you're giving your kids their medicines when they're 6, 7, 8, 9, like letting them know what this is and what's the medicine and why we're giving you this medicine. But really, we start thinking about this in a very serious way starting about 12 to 14 years of age, where we are going to want to have your child know how do you take your medicines? What are these medicines? What do we do in an emergency? And then from there, as they get a little bit older, closer to 18, understanding, well, how do I refill my medicines? How do I talk to the doctor's office or send them a message? And what are those legal changes that are going to happen? Some of your specialists may take care of your kid or yourself if you're listening to this for your entire life. And so there's not necessarily a physical transfer to a different office, but you still need to know what's different about you're managing an asthma as a teenager versus as an adult. So one thing that we're really fortunate to have at Children's Hospital Colorado, and they also have them at several other programs across the country, are coordinators that specifically work with the patient to understand these legal changes. We might ask you some questionnaires to understand your medicine management and understand what you do and don't know about your asthma, and direct education in that way. Because the goal is that while mom and dad have been helpful for you for 18 years, they're not going to be with you every day moving forward. And we want to make sure that you're able to take care of yourself and your own asthma in that regard.
I have a teenager and one that's about to turn 21 in a couple of months. And it's just watching the transition of responsibility in all things and figuring out sort of where you failed as a parent and succeeded. There's both. It's a equipoise that you hope you. Anyways, that's a whole other podcast. But kids with chronic diseases, like, this is important because this is where you could be doing a great job with them in their younger years, staying on top of asthma. All of a sudden you slack off. You think, okay, it's time for you to do this. And if it's not managed right, that kid that never had frequent exacerbations all of a sudden is running into a lot of trouble as a teenager in high school, when they're already not wanting to sort of let people know that they're on medicines, might not take it, might have different ideas about. So like this is really, really key for asthma, for food allergy. And again, I think that this is something that at AFA that we can put some more resources towards in helping parents sort of do healthy transitions with their child.
Adolescence is a time of forging independence, of risk taking, but that's not necessarily the independence and risk taking we want to take as with a
Right.
potentially dangerous allergic or asthma condition. And so being there as a support, providing them the education, that's our goal, is to help support them through this potentially difficult time.
Right. And there is no shortage of sort of ill-advised things that your children may or may not attempt, but risks with your asthma are things that we don't want you to take. This is preventable, controllable, manageable. I got to emphasize one more time, the whole thing with your short-acting inhaler, over-reliance on that is probably one of the biggest risks that we see. So again, if you're using that a lot, that's a sign that you need to see somebody to get on a better medicine. We want to get you on things that can rescue you, but make sure that you're not over rescuing yourself because there are better things that can be managed. I look at it, I think our goal at AFA to look at asthma and asthma fatalities as a entirely preventable outcome. If we do it right, it should never get to that point, not without something else happening. But Bill, thank you for coming on. It's been great to sort of chat and let you sort of demonstrate what you're doing and people like you who are specializing in asthma and all the great things that you can do for the field and for the patients. So I thank you for all the work that you're doing.
Thank you so much, Matt. I really appreciate being here today.
Dr. Anderson and Dr. Greenhawt, thank you so much for joining us today to discuss asthma management, treatment, and steps that people can take to control their asthma. I know I learned a lot of great things today, and I'm sure that our listeners will have a lot to think about, and even this could inspire some conversations for them to have with their doctors.
Well, thank you very much. And if you have any questions, you can always go to our website at www.aafa.org. We have a lot of our resources. That's one of the A's in AFA. There's an Ask the Expert section if you feel you have questions. So please visit our website and let us know how we can continue to help serve you.
Yeah, and to add more to that, we have a lot of great resources on asthma symptoms, treatment, the asthma action plan that was mentioned earlier, a lot of great resources that people can download. We'll also include links in the description for people to check out, and hopefully that information helps. We hope our listeners of the Afternoon Chats podcast found this informative and actionable. Don't miss our future episodes, and remember to like and subscribe to our podcast wherever you listen to podcasts. The information presented in our podcast is educational and not intended to provide individual medical advice. Please talk with your healthcare provider for advice about your personal health. If you have questions or want to talk with someone about asthma or allergies, our Asthma and Allergy Foundation of America online community is always open. You can find it at afa.org/join. Lastly, we'd like to take a moment to thank AstraZeneca again for their support in today's episode. Have a good afternoon, everyone.